Hi, I am Dr. Saqib Mansoor, and this is my channel Learning Anatomy. And I have started with you a series of lectures on thalamus, and today is the fifth lecture, the Clinicals of the Thalamus. So, as thalamus is the main relay and integrative center, the disease of the thalamus will have marked effects. So, thalamus is damaged by degeneration that occurs after disease of its arterial supply, hemorrhage, and invasion by a neoplasm. As the arterial supply is important, so first of all, let's study the blood supply of the thalamus. So first source, this is the beautiful diagram of the blood supply of the thalamus. Focus on the diagram. These are the statics, notice that. And this is the text. So first source is the posterior communicating artery. This posterior communicating artery is a branch of the internal carotid artery. It gives rise to the anterior thalamo-perforating arteries. Here you see these are the thalamo-perforating arteries. These are the thalamo-perforating arteries, right? These are the thalamo-perforating arteries. I will enlarge the picture in the end of this slide and show you again the thalamo-perforating arteries, branches of the posterior communicating artery. So number 2 is the posterior cerebral artery. Posterior cerebral artery, this one, this posterior cerebral artery. This is a branch of the basilar artery, right? This is the basilar artery which gives rise to this posterior cerebral artery, this one. And it gives rise to 3 branches. First of all is the posterior choroidal arteries, right? These are the posterior choroidal arteries, right? They are supplying this thalamus, which is red color. Gives rise to also to the posterior thalamo-perforating arteries, right? It showed the thalamo-perforator, the thalamo-perforating arteries. These are the anterior and posterior ones, right? And then this posterior cerebral artery gives rise to the thalamo-geniculate arteries that supply medial and lateral geniculate bodies and the pulvinar, right? These are, thalamo-geniculate arteries. These are there, thalamo-geniculate arteries. And in the last is the anterior choroidal artery. Anterior choroidal artery. Here you go. This is the interior choroidal artery. This is stemming from this internal carotid artery, right? This is your labeling of the internal carotid artery, giving rise here to the anterior choroidal artery. I feel imperative to zoom in the picture, and here you see all these branches of that. And I talked about these, and all these are the, thalamo-perforator arteries or the thalamo-perforating arteries, right? This is one coming from this basilar artery, and this is from internal carotid artery, one from there. And this is the, posterior choroidal artery also coming. I told you already described. You just now spot it out, posterior choroidal artery. And these are the thalamo-geniculate arteries, right? So this is the thing coming from posterior cerebral artery. And this is the anterior choroidal artery coming from internal carotid artery. So these all supply to these structures in the thalamus, its nuclei and everything. So lesions of the thalamus, the sensory loss is produced by thrombosis or hemorrhage of one of the arteries supplying the thalamus. Lesion of ventral posteromedial nucleus and ventral posterolateral nucleus will result in loss of all forms of sensation that include light touch, tactile localization and discrimination, and muscle joint sensation from contralateral side of body. Thalamus is located centrally amongst other chief neuronal structures. So a lesion of thalamus produces dysfunction of adjacent structures that results in signs and symptoms that overshadow that are caused by thalamic disease. For example, a vascular lesion of thalamus usually affects the midbrain with the consequent coma. Of course, in the midbrain, there is the reticular nuclei, and their damage leads to coma. And a lateral extension of the thalamic disease can involve internal capsule and cause extensive sensory and motor deficits. And of course, internal capsule contains very, very important sensory and motor tracts. And the lecture on internal capsule is the next lecture of mine on YouTube. Surgical relief of pain by thalamic cauterization. Intralaminar nuclei of thalamus take part in the relay of pain to cerebral cortex. Cauterization of these nuclei relieves intense, intractable pain associated with terminal cancer. The thalamic pain is a very important clinical condition. Thalamic pain. What is that? Thalamic pain occurs when the patient recovers from a thalamic infarct. Spontaneous pain, often excessive, right? What is thalamic pain? It is spontaneous pain, often excessive. This is called as thalamic overreaction. Occurs on the contralateral side of the body. The painful sensation is aroused by light touch or by cold and fails to respond to strong analgesic drugs. So abnormal involuntary movements, right? So as this is lying close to the lentiform nucleus, the basal ganglia. So let's discuss that. Chorioathetosis with ataxia can follow vascular lesions of the thalamus. It is not certain that loss of thalamic function is involved in these cases or involvement of the adjacent caudate and lentiform nuclei. Ataxia can arise from the loss of appreciation of muscle and joint movement produced by a thalamic lesion. So this very important thalamic hand, clinical condition characteristic, abnormal posture of the contralateral hand is produced in some patients with thalamic lesions. What is that? You see, this is the thalamic hand, right? So one by one, what are the steps? Wrist. The wrist is, pronated and flexed, right? Wrist is pronated and flexed. And here you go again on these metacarpopharyngeal joint. Metacarpopharyngeal joints are also flexed. And these interpharyngeal joints are extended. So this is the thing. And there is some movements in the hand which is not fast, slow movement, right? Athetotic movement. So this condition is due to changed muscle tone in different muscle groups. So this is now another thing, thalamic syndrome. This is also known as the Dejerine and Roussy syndrome, caused by occlusion of a posterior thalamoperforating artery. I showed already this posterior thalamoperforating artery. It has following classic signs, this Dejerine and Roussy syndrome. Athetotic posturing of the hand. This was the thalamic hand, showed you already, this thalamic hand. And the contralateral hemiparesis, contralateral hemianesthesia, and the hyperpathia. What is that? Elevated pain threshold. When the pain threshold is elevated and there is pain is a spontaneous, agonizing and burning, this is hyperpathia. This is seen in thalamic syndrome. So in the last, this Wernicke-Korsakoff Syndrome, WKS, this is a type of brain disorder caused by a lack of vitamin B1 or thiamine, seen mostly in alcoholics, but sometimes also in patients on chronic parenteral nutrition. So it's a dietary disorder, basically, WKS, Wernicke-Korsakoff Syndrome, disorder of the thiamine deficiency. The deficiency causes degeneration of dorsomedial nucleus of thalamus, mammillary bodies, the hypothalamus, and cerebellar vermis. And in acute cases, what happens in WKS? Patients with the thiamine deficiency present with this triad. This is a typical triad, three things. Number one, eye movement abnormalities ranging from horizontal gaze paresis or nystagmus. Number two, ophthalmoplegia. And number three, there is a confusional state. And the severe cases can result in coma or death. So WKS continues. Patients surviving acute stages show anterograde and retrograde amnesia, believed to be caused by bilateral diencephalic lesions, right? So amnesia occurs in the WKS syndromes, right? Which can be anterograde or retrograde. So loss of memory. However, besides amnesia, patients with WQS commonly have other neuropsychological deficits that suggest dysfunction of frontal lobe, and that includes impairments in judgment, initiative, impulse control, and sequencing tasks. So this is Wernicke-Korsakoff syndrome. So I thank you very much. So the clinicals of thalamus are also completed. So the Diencephalon discussion is almost complete. Now I will discuss with you in the next video lecture, the anatomy of the internal capsule. That will be very detailed and extensive and very interesting. Thank you very much. Support my channel by subscribing and hit this bell icon, and then also comment down below. Thank you very much. Stay safe. Goodbye.